Hello, this is Mirrakhimov. I'm a cardiac anesthesiologist at the University of Kentucky. I also serve as PACU rotation director and point of care ultrasound and transesophageal echocardiography director within the Department of Anesthesiology. Today we'll be talking about lung ultrasonography, which is one of my favorite topics. On this image you also see planet Jupiter, which is one of my favorite planets too. So I decided to put two things I'm passionate about onto one slide. I have no conflict of interest to disclose. Please take a moment to review the disclaimer for this presentation. Our agenda includes the discussion of history of lung ultrasonography, indications, limitations and pitfalls, imaging protocols, and we'll review some cases and some pathologies. Let's briefly discuss the history of lung ultrasonography. Air reflects ultrasound beams, and that's why it was deemed to be no role of lung ultrasonography in the diagnosis and workup of pulmonary diseases. The first report of the use of ultrasound in the workup and diagnosis of pleural effusions was published in 1967. And here is a paper titled Reflected Ultrasound in the Detection and Localization of Pleural Effusion. You also can see the image taken from that paper. Just look at the quality of the ultrasound images at that time and compare them to today's modern scans. In 1995, there was a first report of lung ultrasonography in the diagnosis of pneumothorax. That paper was published by a pioneer of lung ultrasonography, French intensivist Dr. Daniel Lichtenstein. Indications for lung ultrasound include unexplained dyspnea, acute or worsening respiratory failure, suspected pneumothorax, and pleural effusion. So let's review the performance of lung ultrasonography and compare it to conventional chest X-ray. On the left of the graph, you see the data for pneumothorax, in the middle for pleural effusion, and on the right for consolidation. Lung ultrasonography outperforms chest X-ray in all of those three categories. It is not to say that there is no role or place for chest X-ray in the diagnosis or workup of lung disease, but just to highlight the utility of lung ultrasonography. Of note, it is quite often possible to perform lung ultrasound at bedside. Usually doesn't take much time to perform. Unfortunately, there is no perfect test, and lung ultrasound is no exception. It can be difficult to obtain windows in patients who are obese, patients with surgical dressings, and in subjects with subcutaneous emphysema due to interference with proper lung visualization. Obviously, operator inexperience in misdiagnosis can lead to inappropriate intervention and patient harm. Lung ultrasound is not sensitive and specific for the diagnosis of pulmonary embolism, so there's another limitation of that. Let's talk about transducers and lung ultrasonography. You can use linear, curvilinear, and phase array transducers for lung ultrasound. Linear transducers, due to superior spatial resolution, are preferred in the detection of pneumothorax and pleural line abnormalities. Curvilinear and phase array transducers, due to its deeper penetration, are superior and preferred for the diagnosis of lung consolidations and pleural effusion. Again, there's a role for every type of transducer depending on the clinical question. Let's discuss the scanning technique. Most modern ultrasound machines have different imaging presets. Some authors and experts recommend using abdominal preset rather than lung preset due to higher diagnostic value. On this image, you see a proper placement of an ultrasound probe for lung ultrasonography. The probe is placed vertically between two ribs. Here you see that each hemithorax is divided into three imaging zones, zone 1, 2, and 3. Each zone should be imaged in the upper part and the lower part as well. This was taken from the blue protocol of lung ultrasonography. Let's take a look at some of the normal findings before reviewing pathologies. First, let's take a look at this image. This image was taken with a linear probe, and we see two ribs which give us shadows and are also labeled for us as ribs. A yellow arrow is pointing at the pleural line, which is a normal finding. If you look and pay attention to this image, you see that the pleural line is moving or shimmering, which is a normal finding, and when present, excludes pneumothorax in the field of exam. We also see another line called A line, which is also labeled for us, and A line is a reverberation artifact of a pleural line. Again, A line is a reverberation artifact of the pleural line. So this image was taken from zone 4 of lung ultrasound field. And again, review the previous image if you want some refresher for different lung zones. Here you see a kidney, either a spleen or a liver, and a diaphragm. And again, this is a good window to look for consolidations and pleural effusions. Motion mode or M mode can be used when you're not sure whether your lung is sliding or not. M mode gives you superior temporal resolution. Let's take a look at the first image. On this image, on the right part of it, you see a still 2D shot with two ribs, pleural line, and an A line. On the left part of this image, you see an M mode. M mode cursor goes from the soft tissue, then pleural line, and then the lung. The first white bright line or hyperechoic line on the M mode is reflective of a pleural line. Below the pleural line, you see what is called a seashore sign, which is suggestive of lung sliding and essentially excludes pneumothorax in the field of view. Compare this to another M mode image when you see no seashore sign and no sand sign, and this is suggestive of a pneumothorax in the right clinical setting. Or it can also be suggestive of main stem intubation, pleurodesis, or apnea. And again, here you don't see this classic seashore sign, and you see that there is no difference between how the soft tissue appears on M mode and how the lung appears on M mode. This is called a barcode sign. Another finding which you can sometimes see is called a lung pulse. When present, it excludes pneumothorax in the field of the exam. However, it's not a normal sign and can be present in main stem intubation, obstructive atelectasis, history of previous pleurodesis, and apnea. On this ultrasound image, you see a lung pulse. Again, you don't see a classic lung sliding or shimmering, but you see a reflective lung movement because of the cardiac activity. Let's do a question. You are working as a third-year medical student in the cardiac operating room. The medical student is allowed to place internal jugular central line under supervision. Unfortunately, our medical student is having difficulty with dynamic needle guidance. Shortly after the procedure is completed, you notice large anesthesia leak, higher gas flow requirements, increased airway pressures, and hypotension. You performed lung ultrasonography. Each ultrasound finding strongly supports the diagnosis of pneumothorax. A. Presence of B lines, B. Lung curtain sign, C. Spine sign, D. Lung point, and E. Plankton sign. Please pause the video if you need more time to answer the question. And the correct answer here is D. Lung point. Presence of B lines essentially excludes pneumothorax in the field of view. We'll talk more about B lines in next slide or two. Lung curtain sign is present when we typically examine the costophrenic angle, and essentially it excludes a pleural effusion, so it's a normal finding. Spine sign, which is an abnormal finding, is highly suggestive of either pneumonia or consolidation or pleural effusion, because spine sign is when you see spine above the diaphragm, which is not a normal finding. Plankton sign sometimes can be seen in the cases of hemothorax. We'll talk about this a little bit later. So let's review some of the findings which either favor or argue against pneumothorax. The findings which argue against pneumothorax include presence of lung sliding, lung pulse, presence of B lines, and a seashore pattern on M mode. Alternatively, signs which support the diagnosis of pneumothorax include lung point, which is very specific for pneumothorax, absence of lung sliding, absence of B lines, and a barcode pattern on M mode. Absent lung sliding is relatively sensitive, but unfortunately not very specific for pneumothorax. Other pathological conditions which can lead to absent lung sliding include mainstem intubation, pleural adhesions, history of pleurodesis, COPD, bullous disease, consolidation, and apnea. Remember that we discussed the barcode sign on the M mode. The same factors and pathological conditions described here can also give you an abnormal M mode pattern, such as barcode pattern. And on this chest X-ray, you see severe emphysematous disease with large bilateral bullae, which are air-filled spaces due to destruction of normal lung parenchyma, and they do not represent pneumothorax, and they should not require a chest tube, which is actually a wrong thing to do for those patients. Let's take a look at a couple of the ultrasound images diagnostic of pneumothorax. Here you see a linear probe, two rib spaces, pleural shimmering up to the point when there is no pleural shimmering, which is called lung point. Here you see another example of lung point. Again, you see pleural shimmering of movement or lung sliding up to the point when there is no lung sliding happening. To be a true and diagnostic lung point, the sliding lung must appear adjacent to an area of A line without sliding. Let's do another question. You're seeing a patient in the emergency department who presented with dyspnea. You performed lung ultrasound, which is shown here, left lung and right lung. What is the most likely diagnosis? A. Bronchial asthma exacerbation, B. Influenza infection, C. Pulmonary embolism, and D. COPD exacerbation. Please pause the video if you need more time to answer the question. And correct answer here is influenza infection. On this slide, on these two images, you see what we call B lines. And B lines are vertical lines originating from the pleural line and reaching the bottom of the ultrasound image. It is normal to see up to 3 B lines per view. And in this patient, we see more than 3 B lines per view. Bronchial asthma and COPD exacerbations are not associated with B-line pattern. Like we discussed earlier, lung ultrasound is not sensitive or specific for pulmonary embolism. So this patient likely has either influenza pneumonitis or influenza ARDS presented as what is called interstitial lung syndrome. So let's talk a little bit more about interstitial syndrome, which can be due to fluid overload states such as CHF, renal failure, inflammatory conditions such as pneumonia, pneumonitis in ARDS, and interstitial lung disease. Again, most of these conditions, except maybe pneumonias, are typically associated with bilateral interstitial pattern on lung or sonography. Let's do a question. A 43-year-old male patient with history of alcoholic liver disease is being managed in the ICU for distributive shock and variceal bleeding complicated by hemorrhagic shock. we perform lung ultrasound. And what is the least likely diagnosis? Empyema, pneumothorax, nephrotic syndrome related pleural effusion, or D, parapneumonic effusion. Please pause the video if you need more time to answer the question. And the correct answer here is nephrotic syndrome related pleural effusion. Let's review this image. On the right part of the image, you see either a liver or a spleen and a diaphragm. We see that the effusion is not a simple anechoic effusion, but rather has a lot of fibrous strands, which strongly goes against the nephrotic syndrome, which is typically a transudative or non-inflammatory effusion and not associated with any fibrous strands or any complex features. And again, this was a question about what is the least likely diagnosis. Empyema, pneumothorax, and parapneumonic effusions can all look like this because they're all exudative and inflammatory effusions. Let's take a look at some of the examples of pleural effusions, which you can see with lung ultrasonography. On this image, you see either a liver or spleen, diaphragm, simple anechoic effusion above the diaphragm, and an atelectatic lung flowing in the pleural fluid. You also see the presence of a spine sign, which is the ability to visualize the spine above the diaphragm. Again, presence of consolidation or pleural effusion is usually behind the spine sign. Compare this to this image where you see a consolidated lung and fibrous strands. So this is likely to be an exudative inflammatory effusion. And you also see a spine above the diaphragm. Also look at this image too. Above the diaphragm, you see fluid, and if you pay attention, you see that you have this so-called plankton sign, which is highly suggestive of hemothorax. The plankton sign highlights the presence of floating debris in the pleural effusion, and like I said, is usually seen with hemothoraces. Let's do another question. We are seeing a 56-year-old male with history of alcohol use disorder who is in the ICU for respiratory failure. You did perform lung ultrasonography. What is the most likely diagnosis? CHF, pneumococcal pneumonia, viral pneumonia, or hepatic hydrothorax? Please pause the video if you need more time to answer the question. And the correct answer here is B, pneumococcal pneumonia. Let's take a look and review the image. On the right part of the image, you see either liver or spleen and the diaphragm. Above the diaphragm, you see a densely consolidated lung, small amount of pleural effusion posteriorly, a spine sign, and you see white strands within the consolidated lung. If you notice that these white strands are moving with some respiration, which is called dynamic air bronchogram. When these white strands don't appear to be moving, they are called static air bronchograms, which are more common or suggestive of simple atelectasis. So because this patient has a dense consolidation, which is typically seen with pneumococcal pneumonia, and not CHF exacerbation, not viral pneumonia, and not hepatic hydrothorax, which is a simple anechoic transudative pleural effusion seen in patients who have liver cirrhosis. So the consolidation can be due to pneumonia, atelectasis, and lung or pulmonary infarction in the cases of pulmonary embolism. On this image, you see again a consolidated lung and what seems to be static air bronchograms, which are white strands which don't appear to be moving. Again, consolidated lung with static air bronchograms which do not appear to be moving. And compare this to this image. Again, we see ribs, we see what is called a subpleural consolidation, which can be seen in the cases of pneumonia, either bacterial or viral. Let's take a look at this diagnostic flowchart, which can be used in the workup of respiratory distress with ultrasound. Obviously, know your patient, know the presenting history. There are several questions which can be answered with ultrasound, which may help you find the diagnosis. The first question is lung sliding present. When not present and accompanied by a lung point, you'd have a diagnosis of a pneumothorax. When you see lung sliding, the next question is whether consolidation is present, which points towards pneumonia or atelectasis, and if not, the next question is, do you see B-lines? And if present, you can see whether they are bilateral or diffuse or unilateral or limited to one field. And again, please take a second to review this flow chart. So in summary, lung ultrasonography has superior performance compared to chest X-ray for effusions, consolidations, and pneumothorax. It usually can be performed relatively quickly at bedside and potentially can lead to faster appropriate interventions. Again, like with any test, clinical context is essential. Remember limitations and possible harm due to improper diagnosis. Again, thank you very much for your time. Please feel free to email me with any questions or comments about the presentation to the email presented on this slide. Thank you and good luck.